Stress fractures represent the failure of the bony skeleton to absorb repetitive loads. This results in structural fatigue of the bone, causing pain, performance impairment, and potentially a complete fracture. Loading can be intrinsic through transmission of impact forces within the bone or extrinsic via the application of tension across bone from the muscles and connective tissue. As a result, a footballer with a stress fracture may suffer prolonged periods out of the game and require further medical interventions including surgery. Bone strain can be described in a continuum from bone strain, mild, to stress reaction to stress fracture, severe, and, ultimately, fracture. The management of stress fractures generally involves a reduction of the inciting load to restore the normal bone physiology. In some cases, however, stress fractures may require special consideration and treatment. Prevention and early recognition of stress fractures is required to reduce the impact on the player. Bone is a dynamic tissue. It is constantly being remodeled and repaired. The process of remodeling involves the coordinated action of the osteoblasts and osteoclasts, which come together to form a temporary structure called the basic multicellular unit. Weight-bearing or the action of muscles on bone causes repetitive tensile and compressive forces within bones. These forces may result in microdamage to the bone architecture, which is subsequently repaired by the BMU through the process of remodeling. The BMU is also under the influence of hormonal factors, particularly those involved in calcium homeostasis. Stress fractures result from recurrent and repetitive loading of bone, where microdamage occurs at a rate faster than can be remodeled by the BMU. Consequently, stress fractures may result from an increase in the applied load or the number of applied stresses, too much load, inadequate recovery time between sessions, loading too soon, or application of normal loads to weakened bones, low bone density or osteoporosis. Given that stress fractures result from repeated loading, training factors, such as volume, intensity, and surface are thought to be important. Other risk factors may include an inadequate calcium or caloric intake, hormonal factors such as menstrual disturbance in females or reduced testosterone in males, osteoporosis, decreased bone density or bone geometry, muscle weakness, and leg length differences. A significant published work on stress fractures in footballers was done between 2001 and 2009 in 54 elite teams, involving 2,379 players. This study identified 51 stress fractures in 40 players, all involving the lower limb. This equates to a risk of 0.04/1,000 player hours of exposure. While this makes stress fractures relatively rare in comparison with other injuries, these injuries are responsible for significant time loss. Stress fractures were more common in preseason and in younger athletes. All but 3 injuries were considered severe, absence more than 28 days, and the mean return to sport was approximately 3 months to 5 months for pelvic stress fractures. There was also a high risk of recurrence, with 29% of the injuries being recurrences. All of the 51 reported fractures involved the lower limb. Distribution of stress fractures in football. The majority of stress fractures seen in football players involve the lower limb. They generally result in a relatively prolonged absence from sport. Footballers with a bone stress injury typically complain of an insidious onset of pain that is worse with activity and repeated loading. Usually, the patient has no recent history of trauma to the affected area. It is important to recognize that lower limb trauma is common in football, so this may bring attention to an underlying injury, rather. In this site, stress fractures are common to occur. Risk factors. Above all, the most important risk factors to be aware of include rapid increases in bone loading as a result of significant changes in training regime, large imbalances between energy, calorie, intake and energy expenditure, particularly amongst female football players, which can leave them vulnerable to hormonal dysfunctions. In addition to asking about this characteristic pattern of pain, it is also important to ask about factors that may have caused the injury. Intrinsic risk factors. Intrinsic factors refer to characteristics of the individual athlete and refer to such things as gender, endocrine/hormonal function, bone density, dietary habits, and skeletal composition and alignment. Gender. Amongst the general population, women are more likely to suffer stress fractures than men, and 2 to 10 times more likely in the military. Higher rates of tibial stress fractures amongst female football players compared to male players have been recorded. Younger female players who have primary amenorrhea risk compromised peak bone mass. This may in turn increase their relative risk of a stress fracture, or osteoporosis, later in life. Female athletes with menstrual disturbances, particularly as a result of low estrogen levels, are 2 to 4 times more likely to suffer a stress fracture than their amenorrhoe teammates. Bony density. Low bone density may contribute to the development of stress fractures through a reduction in bone strength and the accumulation of microdamage with repetitive loading. Muscle flexibility and joint range of motion may have a direct influence on stress fracture risk by altering forces through the bone. A restricted joint range of motion may increase bone strain magnitude and alter loading. For example, the range of hip external rotation and ankle dorsiflexion have been associated with stress fracture development. Dietary habits. The risks of osteoporosis and subsequent stress fractures are largely determined by the peak bone mass achieved in adolescence and early adulthood. Athletes with restrictive eating habits, a history of eating disorders, low BMI or RED-S are more at risk. Women who have been amenorrhoe for more than 6 months are most at risk. Athletes with poor vitamin D status may also be at risk as this leads to calcium malabsorption. Athletes who train predominantly indoors or at night time, those with dark skin, who always have their skin covered, clothing, sunscreen, or those with excess adiposity will be most at risk. Secondary risk factors for low bone mass include athletes with chronic undernutrition, eating disorders, amenorrhoe, glucocorticoid exposure, coeliac disease, and inflammatory bowel disease. Extrinsic risk factors. Extrinsic factors refer to features of the environment and include things like training load, surface, and footwear. Training risk factor. Any changes in routine that alter the magnitude or rate of bone strain. This may include an increase in intensity, duration of sessions, or an increased frequency of training. A sudden or rapid increase in training loads, for example during pre-season or after a return from injury, is common. Mechanical factors. Hard surfaces or surfaces which are less compliant cause an increase in bone load. A change in footwear or orthotics may also be a factor. Age. Extremes in age lead to an increase in risk. Older athletes may be more likely to have low bone density while children and adolescents are yet to reach peak bone density. Each of these factors may contribute to injury. A past history of a stress fracture places the athlete at a significant risk for future occurrences. The most prominent feature on clinical examination is localized tenderness at the site of injury followed by swelling. Local tenderness is present in 65.9 to 100% of the time and localized edema is present in 18 to 44% of cases. Common sites of stress fractures that can be palpated readily include the tibia, navicular, fibula, metatarsals and calcaneus. In sites where palpation of the bone is difficult due to the depth of the structure, there are some nonspecific tests that can be helpful. Asking a patient to perform graduated activity from calf raises to hopping to jogging can be helpful if it reproduces their pain. An assessment of the athlete's biomechanics should also form part of the examination. As 95% of stress-related injuries occur in the lower limb, assessment of leg length, range of movement at the joints of the lower limb, and foot biomechanics are important areas to assess. The primary investigations used for the diagnosis, and the subsequent management, of stress fractures are radiological. There are a variety of options available to image this type of injury. It is worth noting that certain bones and situations may require a specific form of investigation. X-ray. The X-ray changes of a stress fracture usually occur late in the presentation, if at all. In many cases, stress fractures are never demonstrated on X-ray images. Findings range from a very subtle area of periosteel reaction to a visible fracture line. X-rays may be an early screening tool to exclude completion of a stress fracture in certain at-risk bones such as the base 5th metatarsal, femoral neck and anterior border of tibia. Left X-ray shows periosteel reaction of distal fibula, which is a sign of stress fracture. Right X-ray is pars interarticularis stress fracture. CT. This modality may be required to visualize cortical fractures in bones that are not easily visualized with X-rays. These bones include the navicular and the pars interarticularis. CT should be used judiciously, particularly in children, due to the increased cancer risk from the radiation dose. Bone scan. Nuclear medicine bone scan or scintigraphy uses the injection of a radiolabeled isotope, usually technetium-99. This technique is very sensitive for detecting increased bony remodeling. The radioisotope uptake remains for a period of time beyond clinical recovery of stress fractures, and so bone scan may be less useful in ongoing monitoring of recovery. Also, increased isotope uptake is not specific for a stress fracture, as there may be other causes, including infection or tumor. MRI. MRI provides the benefit of multiplanar imaging of the CT scan with the detection of bony pathophysiology of the bone scan but without the radiation. A stress fracture may be identified as periosteel or bone marrow edema on MRI, as well as visualization of a fracture line in certain sequences. Similarly to bone scan, bone marrow edema is not specific for stress fracture on MRI, and the edema may remain for some time after resolution of the stress fracture. DEXA scan. Female athletes who have a stress fracture, especially when there is evidence of relative energy deficiency, RED-S, should have a DEXA, dual energy X-ray absorptiometry, scan to assess their bone mineral density. This can have an important impact on their longer-term treatment. These should not routinely be repeated more than once every 2 years. Any changes that might occur happen slowly.